Clicker. Brilliant. Thank you very much. Hello, everybody, and thank you for having me. As Natalie said, I'm a midwife in the UK, and today, hopefully, I'm going to be sharing with you some research that we've done and some research that we've yet to do, and hopefully I don't cover too much of what's already been covered because the presentations before mine were brilliant. So this is me, and I have no disclosures, but I do speak at the ECHO sessions that were introduced earlier. And these are the two literature reviews I'm going to share with you. First of all, the kind of main findings we've found so far in terms of the literature that's already been collected. So in 2018, we published care considerations for pregnancy and hypermobile Ehlers-Danlos syndrome and hypermobility spectrum disorders. And then we did a clinical update in 2021, which was featured in the British Journal of Midwifery front page. And it's still the most widely read article in the British Journal of Midwifery to this day, which is exciting because we know that healthcare professionals don't really know a lot about this condition, especially midwives and perinatal staff. So it's really good that we've got something out there that can be referenced by healthcare professionals who come across these conditions in pregnancy. So an overview of pregnancy, like I said, I hope I'm not going to cover too much of what's already been said, but there are massive adaptations in connective tissues to grow and birth a baby. And as we know, connective tissues are throughout the body, so we need to think about all systems, how pregnancy affects them, and also how EDS affects them, and then kind of work out together what that might mean. But they're no longer considered rare. In pregnancy, hEDS is like 1 in 500, as we know, and it takes an average of 16 years for a woman to be diagnosed. So obviously, we're thinking about childbearing women at that time may or may not have a diagnosis of hEDS and what that might mean for them. But concerns could be exacerbated over the lifespan. And when people get pregnant, it's often a catalyst for change, so they're looking to either make changes to their health or something might be exacerbated that brings about symptoms that brings about a diagnosis. So it's a real time for change there. In terms of symptoms significant to pregnancy, we know that there's cardiovascular kind of dysfunction in some cases, orthostatic intolerance, reflux, bowel dysmotility, all of those systems being affected throughout. We know there's increased migraine, problems with all systems, mast cell dysregulation, pain is often reported, anxiety, depression, fatigue is more reported, sleep disturbances, and increased diagnosis of psychiatric disorders as well. So anything that goes with pregnancy in terms of regular symptoms may well be exacerbated for someone who has HEDS. So I'm going to take you through the story of kind of the antenatal period, the intrapartum period, and then the postnatal period. And I won't cover too much about babies and newborns because that's going to be covered by other people covering children. So pregnancy is generally well tolerated. That was kind of evidenced in the previous presentations, but lower rates of fertility have been reported, and the symptoms of pregnancy, like I say, can be exacerbated, or they can be helped by the symptoms. They can counteract each other at the same time. But disabling increases in joint laxity can mean problems during pregnancy, and particularly during examinations or birth, those kind of things that can really exacerbate the problems. Pelvic pain and joint instability are common. Obviously, with pregnancy, you've got hormones making things lax anyway, and then you add hypermobility to that, and you can imagine what happens. It kind of increases there. And again, the sickness, the morning sickness, etc., and all the other problems that come with pregnancy are exacerbated by those hormones and the hypermobility there. So need for early referrals, physiotherapy services, and general practitioners. And increased elasticity with relaxin hormone means that you can get varicose veins and increased gastrointestinal problems there. I won't go into more because they've already been covered. So thinking about varicose veins, vascular services are really good for those types of things, and referrals can be done early on to prevent problems there. Most things can be managed via regular means, as in, we would manage hyperemesis in pregnancy or gastro problems with, Gaviscon or any other kind of digestive help that we would with anyone else, and that's kind of the same for hEDS. They're best managed conservatively, lots of physical therapies, physiotherapies are really good, and all the products out there that can help with mobility during pregnancy. And we can manage cases of diverticulitis conservatively unless chronic symptoms come about, in which case surgery may be required. Obviously, we know lots of people with Ehlers-Danlos syndrome have POTS at the same time, about 70%. So there's no uniform guidance for that, but seek early review with obstetricians and anaesthetists, to engage in timely and evidence-based discussions there. So you can plan ahead, basically. Tailored exercises can be good. They've already been spoken about. Oral hydration can be good, salts, etc. But make sure you're looking out for the hypertensive disorders of pregnancy and not exacerbating those at the same time. And continue any medication that's been prescribed to you preconceptually. Advise that ivabradine is stopped. That's the only one that we think needs to be stopped. So thinking about actually intrapartum considerations when you're birthing your baby or when a baby is on the way. The build up to active labour can be slow, but active labours and birth can be really quite fast. So if you think about all those babies all those women that come into the hospital and say, you know, I'm in labour, and they say, no, you're not, go home, chill out, have a bath, have a paracetamol, and then they'll be birthing in the car park 5 minutes later. Those kind of things, so those precipitate births we see, is something I really want to look into, because I do think there's that link with this precipitate birth, long latent phases where they're saying they're in labour for 5 weeks or something, and then all of a sudden the baby will shoot out. There's lots to be explored there. Unexpected shock to parents and to staff. So it might be useful to plan home birth, either as a contingency to that, to make sure someone can actually be with you, or where appropriate if you choose home birth. It could be dependent on your area and your services, whether that could be appropriate. There's an increased risk of premature birth, but obviously that is contested, as we know in the research. More evidence is needed to decide either way. And the abnormal fetal presentation, obviously if you've got lax uterus, the baby has a lot more room to swivel and move and spin, and we need the baby ideally to be in a head down position for birth. POTS, generally birthing environments that provoke calm and relaxation, will reduce pain, reduce stress, and therefore increase positive management of that. Strategies that promote spontaneous pushing in favour of directed pushing. Really, if you're holding your breath, then your blood pressure is going to shoot up and you're going to get problems there. So it's best to just let nature do its thing. So mode of birth, again, I'm not going to cover too much, hopefully, of what other people have said, but people with EDS shouldn't be discouraged from birthing their babies vaginally with hypermobility type. There are some American cohort studies where more people had a caesarean section as opposed to vaginal birth, but that is an American cohort where caesarean section rates are high in the first place. So we really need to look at that. And those with joint hypermobility are less likely to birth via caesarean section or vaginally with the aid of instruments in other studies. So again, more research needs to be done in terms of mode of birth and the best available evidence there. So consider hemostasis, gentle handling of tissues if we're thinking about things tearing in a different way, optimal positioning during birth and joint support to get into different positions, gravity helping things along the way, but whatever's comfortable. And if there is indication for episiotomy or excessive tissue trauma, you think there's going to be a 4th degree tear, 3rd or 4th, birth via caesarean section might be preferred, because obviously it's not going to heal so well potentially after birth, and then you've got the risk of prolapse with that at the same time. In terms of anaesthetic considerations, we frequently see people say, I can still feel it, and you've given them all of the lidocaine you can give, and you think, well, you must be lying. Well, I don't think it, but some professionals think that, and it's like, actually, no, this person may not have local anaesthesia work so well in terms of having EDS. So we've really been trying to share that word really with healthcare professionals. And also you're looking at like spinal fluid leaks. If you have spinal analgesia there, instability, it can be quite hard for anesthesiologists to administer spinal anesthetics and epidurals. And with POTS, it might prevent reactive tachycardia. So if you're actually trying to reduce pain in POTS patients, then you can actually help symptoms there. And early analgesia in general, and birthing environments which provoke calm are really ideal. In terms of postnatal, some can struggle to recover from birth, both psychologically and physically. depending on what's happened to them, if they've had a positive birth experience or a negative birthing experience. And physically, we know that tissues are more challenging to heal, problematic to heal, problematic scarring there. Abnormal scar formation, hemorrhage is often a thing, both at the time of delivery and delayed postpartum hemorrhage. Pelvic prolapses, so as the pelvic muscles kind of come back together, if they don't come back together the way they were, or perhaps more lax, then you've got risk of prolapse there. DVT and complex perinatal wounds, perineal wounds, sorry. And then also this coccyx dislocation is kind of coming through more and more in the research we're doing, where we're seeing that as the baby comes through, the coccyx is dislocated and then doesn't come back into where it should be post-birth. And increased risk of infections, because you've obviously got the increased problems with healing, and increased risk of anxiety and depression. And we think that's linked back to the fact that people aren't healing in good time. They're recovering from problematic deliveries, and then those problems are exacerbating over a longer period of time, which increases people's risk of those conditions. So postnatal management then, if you're thinking about tissues that don't heal so well potentially, then double deep sutures left in for longer periods of time may support better healing in these cases. Pelvic girdle pain, last line of treatment might be intrapelvic injections or joint fusion, but generally they can be supported with physiotherapy. Multidisciplinary working with all different types of practitioners, that's already been covered in other areas. Working together as a team, bringing together all of those expertise into one kind of clinical management plan is really, really useful. And frequent joint dislocations can be improved with some exercises that have already been covered. And with POTS, breastfeeding can actually be therapeutic because it helps with antidiuretic effects. And migraine, also lactation can have preventative effects for migraine. So it's really useful to think about infant feeding in those terms. As I said, I'm not going to go much into the newborn and pediatrics because that's being covered in other sessions, but a baby born with a parent with hEDS, HSD has a 50% chance of inheriting it themselves. So while we don't want to diagnose at that point, we might think, well, if there are red flags, let's investigate and consider further assessment there. Newborns may have clicky hips, so when we're doing ortholanies or Bartholomew's hip abductions, they could be clicky. Skin feels doughy and may bruise easily, so consider joint support for the newborn when you're doing any procedures there. There's a higher incidence of floppy infant syndrome, prematurity, etc. So really you need to make preparations to accept a baby that may be needing help to transition into the world. And important to document clinical bruising, etc., because obviously we've had one of our participants in one of our studies was accused of lying because they saw bruising on the child and they couldn't work out where it had come from. So if practitioners know this is a possibility that bruising may occur, it's important that they're documented at the time to keep a track of that, to make sure no misunderstandings occur. And then consider hEDS from about 5 years old, so we're not diagnosing it from birth necessarily. So that was kind of the literature reviews that we'd done. Now I'm going to go on to the research that we've done more recently, qualitative interviews. So we did 40 narrative interviews with many people around the UK, USA and Canada. And some childbearing with hEDS will experience an entirely low-risk pregnancy and birth, while others may experience significant issues or anything in between. That was kind of our main finding. It was a very complex picture of these stories, and you can see the reference there if you wanted to go and read the full story. But we estimated in this paper that approximately 1 in 20 pregnancies are affected by hEDS globally. And participants recounted a worsening of symptoms and a postnatal complications and ineffective anesthesia, long latent phases of labour followed by quick births. They were panicked, clinicians were panicked. Poor maternity care resulted in women disengaging from services, not wanting future children, etc. Trauma, stress and anxiety, so not a very good picture there. And these are some of the quotes we had from participants that I'll just share in their exact words, verbatim, to kind of help tell the antenatal story about what happened there. But mainly it was, nobody understood me, nobody kind of heard me. And my favourite quote is the bottom one, which says, "I remember the junior rheumatologist saying, 'You're not hypermobile because you can't touch the floor.'" And I'm thinking, I'm 8 months pregnant, of course I can't touch the floor. So just a little flavour there of the misunderstandings that can happen. And this is the intrapartum story. So the thing that interests me most as a midwife, I've run out several times to the car park and caught babies in the car park after I've thought, well, hang on a minute, an hour ago you were just, in a latent phase of labour needing paracetamol. How did this happen? So I'm really interested in this kind of long latent phase. People telling me I've been in labour for weeks, and then all of a sudden, plop, the baby's out. And these are some of the quotes from people saying, this is what happened to me, really, really fast, didn't expect it. And now we're expecting it more and more with people with hEDS. So that's another area of research we're looking into. But also not being listened to again in terms of pain, in terms of not being listened to, you can't possibly feel pain. I've already given you the anesthesia and things like that, which is really heartbreaking. And then in terms of the postnatal story, I still have problems, I'm still healing, I still have this, I still have that. That was a theme that came through a lot. And the second quotation there is the story I was telling you about with the person who wasn't believed when their baby had bruising. And you can understand the complications that could arise from misunderstandings around bruising on children. Quite problematic there. So after all this research, what we did was put together HeadstTogether.com, which is our website which kind of collaborates and pulls together all of our research in terms of pregnancy and EDS. But it's not just about pregnancy and hEDS, it's about POTS, it's all of our research, it's all of our projects coming together. And I'm part of the core team there. I'm the lead midwife. We've got Dr. Gemma Pierce there, the project lead, and a senior designer there who helps us co-create all of the stuff we do together. So have a look at that. And then what we did again was we worked with the Royal College of Midwives to use those stories that people had shared with us to make clinical scenarios and teaching materials for staff, particularly within the Royal College of Midwives, to do their iLearn modules, so online modules where midwives could get a basic understanding of what to look out for with the knowledge and the research evidence we have so far, and it's unfortunately not very much, and we're building on that. But we were able to use real patient stories to help train clinicians, which was really important to us. And we were also able to co-create with lots of other co-creators and agencies a decision-making tool. And if you snap a picture of that, you can go to the QR code and download it. It's free to download. You can print it out, use it in your own patient notes, or use it yourself to make decisions. And it's just a tool to start the discussion, really, between pregnant people and their care providers. And we hope it gets used widely. So please let us know if you're using it anywhere. We also have a small infomercial, which we had to kind of act out ourselves because it was lockdown and we couldn't get other actors in. So apologies for that. But again, please snap the QR code and please download that and watch it and share it widely, because it's another infomercial video about hypermobile Ehlers-Danlos syndrome and pregnancy. And this is really having an impact. A lot of what we're doing is very exciting, and it kind of motivates us to keep going because we're having this impact. So this is a tweet that was shared with us kind of in 2018. Look, I downloaded your stuff. I wasn't going to have a baby, but I downloaded your stuff, had a chat with my healthcare providers, and then a couple of months ago in May, this person got back to us and said, I did it. I had my second baby because of your stuff, because of the tools you'd co-created. So this is what keeps us going. So any impact, anything you download for free, and anything that helps or you use in your practice, please let us know, because it's really exciting for us. But what's next? So we've got lots of plans with HeadstTogether.com and the Ehlers-Danlos Society Consortium, etc., to build on pilot work. We've done large survey publications with staff and with patients to see what's happening out there, what's coming together in the world, and we're putting those together as publications now, hopefully to be submitted and published soon, so there'll be more research out there, large scale. We'd like to do more open online courses, big, massive open access courses for people to access clinicians and people who birth with hEDS. So that's what we have in the pipeline. And within the Ehlers-Danlos Society International Consortium, we are currently, and we've just been in the room this morning talking about it. We are currently pulling together the international guidance or consensus guidelines on the management of pregnancy in cases of hEDS and vEDS as well. So they won't happen quickly because it's quite a large task and we're working with lots of people with amazing expertise, but we are pulling those together, so there'll be hopefully a publication on hEDS and pregnancy guidelines and vEDS and pregnancy guidelines for clinicians and patients to look at and help them guide in their care, because there's obviously lots of conflicting advice, lots of conflicting things people are worried about, etc. And also there's lots of clinicians out there that just simply don't know what to do when they're faced with this. So we're hoping that will be really, really useful in practice and impactful again. And we would invite you to come and talk to us, any of the team, myself, or any of the other team involved in the guideline co-creation, because we're really interested to have public consultation on this, see what you think needs to be included, what would you have liked your healthcare provider to know when you had your baby, and what would have helped at the time, because if we can add that into the guidelines and it helps someone else, then that's brilliant. So that's what we're doing. We're busy bees, but I'm really glad to be here because it means that we can bring everyone together in co-creating the way forward. So I'm just going to leave you with this last slide, which will link you to HeadsTogether.com. And the reason I've used that slide is, again, because it shows our partners. So Coventry University, where I work, the Ehlers-Danlos Society is helping us there, EDS UK, the hypermobility charities, the Royal College of Obstetricians, Royal College of Midwives, obviously because UK focus, and the Make Birth Better initiative. So I just wanted to mention that this is no way me doing this all by myself. This is people coming together, bringing their knowledge in public, sharing their opinions and their needs and their ideas with us so that we can co-create things that are really useful in practice. So thank you for listening and thank you for having me here. I'll be delighted to speak to some of you in the panel session or after the presentations. Thank you.